All right. Well, our next presenter is Dr. Katie Metrock. Dr. Metrock is the assistant professor in the UAB Heersink School of Medicine Division of Pediatric Hematology and Oncology. She is also the program director of the Neuro-Oncology Fellowship Program. And today, Dr. Metrock will be presenting Pediatric NF Care and Clinical Trials Update. Dr. Metrock.
Okay, thank you for having me. I am going to attempt to share my screen. All right. Are y'all able to see the slideshow?
Yes.
Okay. All right. So I'm excited to be here talking about something we're all very passionate about, of care of patients with NF. My focus today is going to be on clinical trials, and then specifically some of the current pediatric clinical trials that we have open. I have no disclosures today. All right, first I do want to introduce our team, your team if you're a patient with us. So we have 4 neuro-oncology physicians in our divisions, Dr. Dahl, Friedman, Alva, and myself. We have 4 nurse practitioners, Marla, Kara, Sasha, and Angie, who if you're in our clinic, you get very familiar with them. We have a Hope and Cope team, and this team is really special. It consists of neuropsychologists, Dr. Avi Madden-Swain, Dr. Emily Warren, Dr. Donna Murdaugh, and you'll hear from Dr. Warren later. So they help us to better understand what each patient is going through, what NF means for that particular child. And Carolyn Davis is our school teacher, who's fantastic. She really helps bridge that gap between the clinic and school and the needs for each child there. We have social workers and a chaplain. We have an advanced and palliative care team. And we also have several other people that we collaborate with in the Department of Neurosurgery, Neuroradiology, Pathology, Radiation Oncology, and then of course, genetics, Dr. Korf and Tammy Skelton. So a big team of people trying to make things better. All right, so clinical trials. There's some key terms when we talk about clinical trials, and some people watching may be really familiar with clinical trials, may have been a part of a clinical trial. And for other people, it may seem like a bit more of a vague concept. So I wanted to go through this today. Some of the key terms: a sponsor, who sponsors a trial. So it can be an institution, a company, or an organization that helps pay for the trial and coordinate all that goes into that. And often it'll be an institution working with a company now. It's not uncommon, for example, for the NF consortium to be working with AstraZeneca and Alexion with selumetinib to run a clinical trial. The principal investigator is the person in charge. So this is the person that really heads the trial. They help, they're the biggest in writing the protocol and the trial design. The protocol itself is the plan for the trial. So it will include all the information necessary to move the trial forward. So eligibility criteria, who can participate and who can't participate, the number of people that are needed to complete the trial. That's important because in order to get the most out of a clinical trial, we need to have enough patients to answer the question. So if we have a trial and we don't enroll enough patients, then we're not going to be able to really fully answer the questions we're trying to. It will include the drugs in the trial, the dose, how it needs to be given, all the tests that need to be run to make sure that the patients are safe, and then what information we're collecting. Often it's, the obvious questions are about if we're doing a trial for a tumor size, is the tumor getting smaller? But there's also other questions that we can answer in terms of quality of life on that trial. How do the side effects affect the people involved? From Dr. Warren's perspective, there can be good information about neuropsychological side effects or progress on the trial. So the protocol helps us clearly define those goals. Each trial has a phase, and that broadly identifies the main questions being answered. I'll go through that in a little bit. And then there's also the informed consent and assent aspects of clinical trials, which I'll go into more detail about. So for the eligibility criteria, we have both inclusion and exclusion criteria. Inclusion criteria will be, what tumor types will we accept and which ones don't qualify for the trial? What kind of progression should the tumor have grown before the child can enroll in the study or not? What prior therapies are allowed or not allowed? And this is coming up a lot with NF trials because some of our newer trials, we may not allow patients that have previously taken a MEK inhibitor to be on a trial that's combining a MEK inhibitor with another drug. And that's to try to limit we call confounding aspects of kids that have their tumors have already seen the MEK inhibitor. Excuse me. So which therapies are going to be allowed and which ones aren't? The age range, how young can kids be to participate, and then also how old? Is it going to be more of a pediatric? Does it allow adolescents and young adults, and how high does that adult age range go? There's a performance score sometimes required, and what that means is it's there for a safety reason. If a child is really struggling for whatever reason, and they have a performance score that doesn't meet the criteria, it's a safety lock to make sure that we're not giving medicines to children that we could be hurting. Organ function. So we want to make sure that the lab, the liver and the kidneys, everything is working the way it's supposed to work, so that the drug is metabolized the way we expect it to be. Again, safety. And they can also be echo and EKGs, making sure the heart's safe. Pregnancy test when that applies. How far out from a recent surgery or radiation do patients need to be before they can go on the trial? And then other diseases or disorders that might affect the response. The clinical trial phases. Again, each phase is designed to answer a question. And most of the time we think about phase 1, 2, and 3, but there's actually a phase, it goes from phase 0 to phase 4. So phase 0 is exploring if and how a drug may work. And that's usually only necessary if there's still some unanswered questions between what we call the preclinical work, what's been done in the lab, before we move it into people. And so this may be a very small trial that just helps us learn a little bit more about how the drug is metabolized, how it affects maybe the liver, that sort of thing. And then the drug, so it doesn't have to go to a phase 0, but it might. Phase 1 answers the question of, is the treatment safe? And these trials are very important, and they can be very difficult at the same time. So often it will include different dosing schedules. So some patients may enter the trial, for example, at a very low dose. And if we show that that is safe, then we enroll patients at a higher dose. And if that's safe, we see if it can be a higher dose until we reach something called the maximum tolerated dose. We want to get to the maximum safe dose before moving into the next phase of learning about, does the trial work? Of course, we always hope that in a phase 1, we're going to see results, that it works on the tumor. But the actual question that the protocol is geared to answer is about the safety of the medicine. The phase 2 is, does the treatment work? So that's where we're looking at, does the tumor shrink? If it does shrink, how long does it stay smaller? We're still also looking at safety and the other aspects of the drug, but the main question is about, does it work? Phase 3 is, does the treatment work better than what we're currently doing? So this may be, for example, a randomized study where we take the medicine that we've learned a lot about in the phase 1 and phase 2, and some patients get that medicine while other patients get the current treatment. And then we compare the results for both. We compare the results, we compare the side effect profile, and decide whether or not it's reasonable for that medicine to be considered for patients off study later. So if that's the case, then the drug can be approved for that indication, approval by the FDA. And sometimes we'll move into what's called a phase 4, and that's just learning more about the treatment, long-term side effects, long-term efficacy, Sometimes it's called a post-marketing trial, and that can include hundreds, thousands of patients. But phase 1, 2, and 3 are the main phases that you'll hear about. Informed consent. This is such a hugely important part of clinical trials. So this is the permission granted with the knowledge of all the consequences, with the full understanding of the risks and benefits. And that, can be all summed up in that single sentence, but there's really so much that goes into that. The 4 main components are: 1, the patient, and on the pediatric side, the family, the parents have to have the ability to make the decision. And then on our side, as the providers, we have to be able to put all the information out there about the risks, the benefits, the alternatives to going on this study, and make sure that family, that those patients understand what the trial entails. And that's a tough decision, and I've often seen families struggle with that, to decide if they need to put their child on the trial. But that's where it becomes a real discussion about the child, for where they are in life, what they need, the family, and it becomes a discussion with us as the care providers. Is this in the best interest of this child? And everybody must be able to comprehend that information. And then the consent must be voluntary, so there's no coercion or duress. And some people often ask, like, well, do we get paid to be on clinical trials? Some trials do offer some stipends. You never want a person to go on a trial because they're getting paid, right? They want them to enter into the trial because they understand the risks and the benefits, and they feel like it's in the best interest for what they're going through. But trials are a commitment. There's often some extra visits to the clinic, and for some families that means a lot of extra travel. It might mean nights at what we have our Ronald McDonald House or the hotels. It's a lot of extra stress sometimes, and so we want to be able to help with that when we can. And assent, this is along the same lines as informed consent, but for pediatrics, children are not legally allowed to give consent until they're 18 years of age. So assent is something we have that allows them to participate in the conversation. It's the agreement for them to take part in the trial. Sometimes it's a verbal agreement and sometimes it's written. It's not often legally required, but most of the time our IRB does require it. And IRB is the institutional review board that oversees the trial and the protocol to make sure that it's being run correctly. And we're expected to get assent unless the child's not capable. Maybe developmentally they're not there yet. Maybe they're a baby and they can't give us that consent. The treatment is the only available beneficial option, and the situation is significant enough where all the adults feel like it's necessary. And the treatment is only available through the trial. We couldn't give it to them off study. You can find clinical trials online. 1, you can also discuss with your doctor, but 2, there's online tools, clinicaltrials.gov. Most trials are listed there. And when you go to the website, it offers a keyword search, and you can filter by country, by state. You can add special filters that apply for you, how far you're willing to travel. And it gives a little summary of the trial and contact information. Here at UAB and Children's of Alabama, we have many opportunities for clinical trials. So specifically in Neuro-Oncology, we're a part of several consortium, and Dr. Korf talked about the NF consortium. A consortium is a group of institutions that come together to run trials. The reason that those are important is that it allows us more opportunity to enroll more patients, and more patients of various demographics across the country and sometimes even across the world. So the Children's Oncology Group is a huge organization that runs many, many trials, often phase 2 and phase 3 trials that answer questions about all kinds of disorders, cancers. But there's a specific group within the Children's Oncology Group, or COG, that focuses on neuro-oncology. We're also part of the PEP-CTN that runs phase 1 trials, or developmental therapeutics trials. We're part of PNOC, which is the Pacific Neuro-Oncology Consortium. It seems kind of funny that we're in the Pacific Neuro-Oncology Consortium, but they're kind of spreading out across the country now. The Sunshine Consortium, which is mostly concentrated in the Southeast. And then of course, the Neurofibromatosis Clinical Trial Consortium. And these maps just give you an idea. This is the PEP-CTN map to show where these institutions are located around the country. This is PNOC, that I told you, the Pacific Neuro-Oncology Consortium. It's kind of all over. And then this is the NF Consortium to show where those sites are located, where patients can enroll. All right, now I want to spend a little bit of time on what trials we have for plexiform neurofibromas and then also low-grade gliomas and sort of where we've been and where we are, and then we can go into future directions and where we hope we're going. All right, so Dr. Korf has already talked about this, so I won't spend too much time, but plexiform neurofibromas are present in at least half or more of patients with NF1, and they often grow more rapidly in early childhood. And basically they're just abnormal cells in the nerves. And you can see here on the left, this is an MRI where you can see the large plexiform on the side of the head and neck. And then on the right is just a look at how a neurofibroma and a plexiform neurofibroma look. So treatment options. Observation is always an option, and it always has been. We watch and see if it's not causing problems, and we just keep watching. Surgery is sometimes an option. If it's an isolated neurofibroma that the surgeons feel like they can go in and take out with minimal damage. I will say most of the time when there's a surgery involved with a plexiform neurofibroma, there will be damage, right? These are nerve tumors. So you are going to disrupt nerve function in whatever area the surgery is happening. But if the nerve is one that allows, I'll give you an example. There's a neurofibroma on an arm. Can they take it out and still allow the hand to function, but maybe the patient just doesn't feel as much? It just becomes more of a numb skin over that area. That might be something that, if the patient understands that, says, okay, that's worth it, let's get it out. That's maybe a reasonable option. But a lot of these plexiform neurofibromas are not amenable to surgery. They're big, they're complicated, and going and taking a piece of it out, what we have learned in the past is it often grows back, or we just end up causing more harm than good. And now that we have some treatment options, I find that surgeons are even less and less likely to want to perform surgery, and I'm much less likely to recommend it. I've included a few drugs on here that were used, that went through clinical trials in the past, to show the importance of that. And maybe some people on here were a part of those trials or knew somebody who was. So we tried different drugs through clinical trials, and they didn't show the effect we were hoping for. That's always frustrating. When we run a trial, we've put our patients on there with the hope that something is going to improve, and then overall it doesn't. But I want to include that for the thought of how important that information is, because if we weren't coming together and doing these studies in a standardized way to learn information, then physicians around the country or around the world could still be trying to give these drugs, thinking that they had one patient who responded some, so maybe the next one will, maybe the next one will. But we've learned through these trials that they're not overall going to help patients the way we intended them to. However, we've had some drugs that have shown some success. So I'm going to talk a lot for plexiforms as well as low-grade gliomas about mTOR inhibitors and MEK inhibitors. So Dr. Korf went into this pathway, the RAS-RAF pathway, and the details of it aren't as important as just the overall concept. He used the word dominoes, and I think that's a very good way of thinking about this. So your cell needs to move through this pathway to divide. a lot of times that's fine when we're using these pathways for cells that are doing what they're supposed to do. But in NF, these cells are not doing what they're supposed to do. And so we want to block these pathways. If you block one, there's potential that the cell uses the other side of the pathway. So we have to say which pathway might be the dominant pathway. Can we block both pathways? Those are all questions we're trying to answer. So mTOR inhibitors are drugs like sirolimus and everolimus. MEK inhibitors are drugs like trametinib, selumetinib, binimetinib, mirdametinib. And these drugs can all be taken by mouth, and they specifically target this pathway. I'm going to go through a few examples of some studies with their results to, again, walk us through kind of where we've been and where we are. So sirolimus was a drug used for plexiforms. This is the study title. It was a phase 2 study in kids that were older than 3 years of age, and they were able to enroll 61 patients that we could use all of their information. We call them evaluable participants. And we didn't see any efficacy in non-progressive plexiforms, which means plexiforms that weren't growing to begin with. It didn't really seem to shrink those. But in progressive plexiforms, so those plexiforms that were growing when the patient started the medicine, we saw some improvement in their time to progression. So it seemed to have some sort of signal in tumors that were being active where this pathway was being used. Turning it off seemed to help slow it down for some patients. Not significantly and not good enough, right? It was still good information for us to learn about, but it's not where we wanted to be. We saw similar results with everolimus. So what about MEK inhibitors? So again, interrupting this pathway. Trametinib was one of the first MEK inhibitors approved by the FDA for treatment in melanoma. Other MEK inhibitors are selumetinib, binimetinib, mirdametinib. Again, taken by mouth, which is usually good. I'll get into that in a second. Plexiform neurofibromas were studied with the SPRINT trial with selumetinib. So this was a huge trial. Phase 2, it took place between August of 2015 and August of 2016. So we were able to put 50 patients on this study. And these patients had to have plexiforms that were causing problems. So you'll hear about that. You'll hear them say plexiform neurofibromas that were causing morbidity. That means they were causing problems for the patient, or in a place that could be dangerous. For example, near an airway or over the eye where it could affect vision. Patients were 2 to 18 years of age, and they received selumetinib at 25 milligrams per meter squared, which is the same dose we use now, twice daily, in 28-day cycles. So each cycle is 28 days, and then the next cycle starts. And when you hear us talk about different medicines and therapies, you often hear us say cycle duration. There was a partial response, and that means more than 20% decrease in tumor size in about 35 patients, so close to 70%. And 28 of those had a durable response, meaning it lasted over a year, which is really an important number. You want the tumor to shrink, but you also want that shrinkage to last. An additional 12 patients had stable disease, which can be a success. I know if you've ever been in my clinic, you'll hear me say, stable is good. Of course, shrinkage is better. Shrinkage is what we want, but stable can be good. If you're having a plexiform that's causing problems and we make it stop growing, we'll count that as success. In addition to just tumor shrinkage, patients reported decrease in pain. They reported daily functioning was improving, overall health and quality of life, strength, range of motion. 5 patients did stop the medicine because of toxic side effects we'll talk about. And then 6 patients had tumor progression. So this drug has offered us an opportunity to help treat so many patients. but it's not perfect, right? No medicines are perfect. And there are a lot of side effects that I'll talk about. And then for some patients, it just isn't working. And there's a lot to learn there. Why is it working for some and not for others? This is a graph that shows that progression-free survival. When they looked at the patients that were taking selumetinib and those that weren't, just the natural history, the patients that were taking selumetinib were going a longer period of time without the tumor getting bigger. That's what that means. The FDA granted breakthrough approval and then actual approval 2 years ago. So it's in 3 to 18-year-olds, symptomatic and or progressive, inoperable, NF-related plexiform neurofibromas. So again, it's approved by the FDA right now for symptomatic or tumors that are getting bigger. We're learning, we have another trial that's coming in the pipeline for tumors that aren't growing, to see if we can prevent growth and prevent the problems before they start. That is not yet enrolling, but hopefully it will soon. We've looked at other MEK inhibitors as well. Binimetinib was open for a while. It accrued patients greater than 1 year of age. It is close to accrual. I've seen some of those results, but I don't actually think they're published yet. Mirdametinib is another medicine. The first study looking at it enrolled 19 patients with a partial response, and 8 out of 19 and 10 out of 19 had stable disease, and 1 patient progressed through it, meaning just didn't respond. The next trial with that was MEK-NF201 that was run through SpringWorks and MedPace. It was a well-done study, and this medicine, mirdametinib, actually comes in a liquid formulation, which is great for our little kids. But it is now currently closed to accrual, and we're in both the adult and the pediatric arms, and we're waiting on those results. Side effects. So this is a big point to talk about. I have a lot of people that come to the office because they've heard about these MEK inhibitors and they want to learn information. But we have to weigh the possible shrinkage of the tumor versus the side effects. And that is a very patient-dependent conversation to have, of how these side effects will affect their day-to-day quality of life. So the most common are rash, and that rash can look different for different people. So I tend to see that this is my experience, is that my teenagers get more of the acneiform rash or acne. So they get it on their face, on their chest, on their back, sometimes all over. And we often have to start another medicine like an antibiotic, like doxycycline, with the MEK inhibitor to help prevent that rash. The little kids tend to get more of a like almost eczema or sunburn type rash that can respond to topical steroids, but I've seen it get pretty significant at times. There can be swelling due to fluid retention. So I see a lot of my patients that they kind of gain some weight. And again, some are more sensitive than others. I have plenty that don't. And then some of my little ones, they just retain a lot of fluid while they're taking the medicine. Elevated CPK or creatinine phosphokinase. So this is a enzyme that we look at. It can be broken down by your muscle. And if the breakdown happens really fast, some people get sore and they feel kind of muscle aches. But usually in these patients, we find it on the lab before the patient really seems to notice anything is going on. The big thing is that you want to make sure the number doesn't get so high that it overwhelms the kidney, that will filter that. So if the number is too high, we will hold the medicine, sometimes make dose adjustments. Some patients describe feeling weak or tired. I do sometimes see changes in hair. So it can be hair thinning or a lightening of the hair, and also the skin. Some patients get really pale on the medicine. And when they stop taking it, it goes back to their baseline coloring. And what can happen sometimes with the hair is if there's a lot of starts and stops, lots of holds in the medicine, for some reason, there can actually be little stripes. That's where you can tell where the hair was, where they were on it and where they were off the medicine. Again, that's not everybody, but it's it's some patients more than others. This one's frustrating. So paronychia, or infection of the skin around the fingernails or toenails. So this would be like, almost can look like an ingrown fingernail or an ingrown toenail, and you have to have the patient soak and little bleach bath soaks. Sometimes we have to hold the medicine, sometimes we have to give an antibiotic. I've had some patients that wanted to stay on the medicine so bad, but they hated having their toenails get these infections that they actually had the edges of the toenails clipped by the podiatrist. So it's always, again, it's a risk and a benefit analysis of weighing what's best for the patient. Less likely, so 10 to 20% of patients can get muscle pain or muscle spasms, weakness, anemia, which is reduction in their red blood cell counts. I have heard of patients getting significant anemia on these medicines. In general, most patients don't. Most patients hold on to their blood counts. The patients I've had that have had more issues with anemia are ones that have been heavily pretreated with other medicines in the past. Specifically other really hard chemotherapy medicines for other reasons. They can get decreased protein or albumin in the blood, and then the weight gain, which can be water retention or true weight gain. So these other side effects that are less common, but are important to talk about. Some patients do describe a change in taste, but more severe ones are blockage or tear in the stomach or intestines, bleeding events, blood clots, change in the heart rhythm, or decrease in the ability of the heart to pump blood. I do see this from time to time. So in general, we pick up on this before the patient notices any different. So we do echocardiograms every 3 months for the patients taking these medicines, echoes or ultrasounds of the heart. And we watch what's called the ejection fraction, which is how much blood is pumped out of the heart with each beat. And if that ejection fraction is decreasing to a number that's less than normal or just decreasing from the patient's baseline, we will stop the medicine, hold it. The heart in these children does really well, and it recovers back to normal. And then sometimes we restart at the same dose, or restart, if depending on the situation, often a lower dose, and they tolerate it fine. But it's something that we take very seriously and pay a lot of attention to. We watch kidneys and liver, pay attention to blood pressure because that can increase. Diarrhea is sometimes a problem. Most patients respond to loperamide or Imodium. I have one patient that would take Imodium once a week and said that was enough to kind of keep things regular. Dizziness or fever. We've also studied a drug called cabozantinib in patients with plexiform, and this targets blood vessel formation in the supporting cells of the tumor to help make it shrink. This was done in patients 3 years and older. It is now close to accrual, and those results are pending. All right, moving on to low-grade gliomas. So a glioma is a tumor of the brain or spine. So glial cells are kind of supporting cells in the brain. These are actually the most common pediatric brain tumors outside of NF, with an incidence of 2.1 per 100,000 children. Children with NF have a 15 to 20% likelihood of developing a low-grade glioma. Oh, and I'll go back here. The top shows an optic pathway glioma. So you can see it's actually the patient's right, but it's on your left. That is an optic nerve. So this is like looking down at the patient with the eyes in the front, and the bottom part is the back of the head. So this, where this red arrow is, this part, this bulging, is the optic pathway glioma. And down here, this is another glioma that's more in the parenchyma of the brain. So the question is always with these, do they need biopsies? In general, no. Patients with NF, we do not have to biopsy. They have a very classic appearance on MRI. You would not want to biopsy an optic pathway tumor because that would cause vision problems or blindness. And do they need to be treated at all? So often specifically in patients with NF, we can observe these tumors because we have learned enough to know that most of the tumors are not going to cause problems. And so we can do more problems by treating than just watching carefully. And so that involves surveillance MRIs, vision exams, and endocrine function, because you actually have part of your hormone center is located right beside where these optic nerves from each eye meet in the back, called the chiasm. And so if there's tumor there, sometimes it can disrupt that function. So in general, we watch until there's issues with, usually with vision. And what that is, that can mean different things for different patients. And so it takes a team of people to be watching these carefully and making sure the patient's safe. Surgery depends on the location of the tumor and if it's causing symptoms or not. If a tumor is causing problems or seemingly in a place that could cause significant issues or growing too much, the standard of care is traditional chemotherapy. What I mean by that is chemotherapy that usually is given through a port, which is a special IV that goes into a bigger blood vessel than the ones in the arm. And therapies that we use are something called carboplatin and vincristine or vinblastine. Now, these medicines are not given at the same, carboplatin specifically is not given at the same dose that causes a lot of the side effects that people think of when they hear chemotherapy. When we give chemotherapy to high-grade tumors or tumors that are rapidly dividing, that type of chemotherapy, we have to give a lot of it pretty quickly, and then we let the body recover and we give more. That hard kind of chemotherapy makes people feel really sick. And in general is what most people picture in their minds when they're thinking of this chemotherapy. The regimens that we use to treat low-grade gliomas, low-grade meaning they're growing slowly, and usually we don't expect these to spread to other places. That kind of low-grade chemotherapy, so to speak, is given on a more consistent basis. So it means more office visits. Carboplatin is given over several hours, vincristine is given over a few minutes. But every week with a few weeks built in as a break over a little bit more than a year's worth of time. So it's a lot of office visits, and kids might feel tired and a little bit sick, but usually they still get to go to school for the rest of the week and tolerate it okay. There can be allergic reactions, which send us down a whole different path. So traditional chemotherapy is often effective, not always, but often effective at slowing down or shrinking these tumors. But we still want better therapies, less side effects. And that's where we hope that we can start using the same targeted therapy in patients with NF. So can we target these same pathways and shrink the tumor in a way that will be sustainable, right? So it doesn't come back. There was a study looking at binimetinib, the MEK inhibitor binimetinib, in children with progressive or recurrent low-grade glioma. So these are kids that have been treated with other medicines in the past, but the tumor keeps growing. We saw a partial response. This is all courtesy of Dr. Robeson. So a partial response, which is a 50% decrease in tumor size. So again, this is different than the plexiforms, right? A partial response was a 20% decrease, but in low-grade gliomas, a partial response was 50% decrease, and a minor response is a 25% decrease. We enrolled 57 patients on that, and 44 patients with preliminary response data showed a 50% response rate. So partial response in 15 and a minor response in 7. Most common, well, these are called AEs or adverse events. And 3 and 4 are the more serious. 1 and 2 are not as serious. So grade 3 or 4 adverse event, increase in that muscle enzyme I told you about, CK or CPK, rash, truncal weakness, which is an interesting one that we're still trying to learn more about. Some kids felt less stable in their core, and some of that was significantly so, and it improved when they stop the medicine. And then transient colitis, which is kind of intestinal irritation in one patient. Again, Dr. Robeson kindly provided these images. So this is an MRI looking at a tumor. And this is a side view. Before we were looking down, this is looking at the side. So obviously eyes, nose, mouth, back of the head, spine, tumor. This is the baseline. So this is what the patient looked like when they first entered the study. This is 1 month into the study, 3 months into the study, 6 months, 9 months, a year. That's pretty dramatic response. Again, not everybody responds that way, but some patients do, and it's very hopeful. So this is another low-grade study looking at selumetinib. It was another phase 2 trial, looking again at patients that had previously received traditional chemotherapy, and then the tumor grew back. To include patients 3 to 21 years of age. Again, the partial response is a 50% reduction. Stratum 1, so these patients did not have NF. And this stratum was actually stratum 3. The patients did have NF. And so in stratum 1, 9 out of 25 patients had a partial response. And in stratum 3, 10 out of 25 patients had a partial response. But what I want to draw your attention to, this is where they started. This was whatever their baseline tumor volume was, is this line. This is a decrease from that baseline. So if you look at the patients with NF, they all showed some sort of response to getting the medicine, even if they didn't reach that 50% mark, which is highlighted here by this dotted line. Not all of them continued to have that response, and some patients did have tumor that grew, but a significant number of patients did respond and continue to respond. This study led to a bigger study. This is through the COG group that I told you about, Children's Oncology Group. So this is looking at NF-associated low-grade gliomas, comparing selumetinib to the traditional carboplatin and vincristine medicine. So again, this is that phase 3 study we talked about. The question is, does selumetinib work as good as what we've been doing in the past? It includes patients 2 to 21 years of age, and they actually are newly diagnosed. So not patients that have progressed, but we first learned about their tumor and they've never had treatment. Then we go to randomizing them. We don't get to choose which arm they go on, the study tells us. And if they progress during one of these treatments, they can go to the other side. All right, I'm running out of time, so I'm going to move through this. We did also see some signal in an NF consortium study looking at everolimus in patients with NF low-grade gliomas. So 22 patients were looked at, 15 showed response, and 10 remained free of progression after they followed up several months later. So this is targeting the other side of that pathway, right, mTOR. Now we're trying to combine these two. Is it safe to give trametinib and a MEK inhibitor and an mTOR inhibitor together? This is a PNOC study, that consortium I told you about, PNOC 021. It's currently in a phase 1 stage. To enroll in this, you actually have to have tumor tissue. So there's not going to be a lot of NF patients on this study right now, because most of the time we don't need to biopsy those patients, and we're not going to biopsy them unless we need to. So if this proves safe in the phase 1 phase, it will move into a phase 2 phase that could potentially have an NF arm that does not require biopsy. We're not there yet, we'll see. There's also another immunotherapy option right now called NF-111, run through the NF Clinical Trials Consortium. This is poly-ICLC. It's a really big name. And this is an immunotherapy. It's helping use the immune system to fight the tumor. It's given as twice weekly injections, and we are currently enrolling patients on this study. All right, so in the future, will combining these therapies help? Is it safe, and does it make an even better response? What role will immunotherapy or immunostimulants have in fighting these tumors? Some of the questions we need to answer are: who's going to respond? When is the best time to treat a plexiform or a low-grade glioma? Is it before there's problems? Maybe. How long should we treat for? That's a big question. Sometimes we treat for 2 years and we stop and see what happens, but maybe not. Maybe we need to just keep treating. That's still an unanswered question. What are the long-term side effects? 10, 20, 30 years down the road. And how do we get the most durable response, the most long-lasting response? We still need more advances in NF2 and schwannomatosis. I think we're going to get there, but we need the research and we need the funding. And then perhaps in the future, we'll have more precise, personalized treatments. Actually take the tumor out, test different drugs on it, see what works. Those are all possibilities for the future. All right, and with that, I am finished. Thank you very much for your time. And I look forward to hopefully answering some questions later on.
Thank you so much, Dr. Metrock. I think we are moving into our break, but one question before we move into our break time that may be relevant to both you, Dr. Metrock, and you, Dr. Korf, and possibly Dr. Neighbors, who we'll be hearing from right after the break, is MRI imaging for baseline evaluation. So right after a diagnosis, maybe it's a pediatric child, what are your thoughts on baseline imaging for brain, neck, and spine when there's no known clinical concern, I guess, in a proactive way?
I guess I can start on that. Others can chime in. So the consensus guidelines, and there are published guidelines for both children and adults, do not recommend baseline imaging studies. That is to say, imaging in the absence of signs or symptoms of a tumor or some other kind of lesion. And the reason is that although you may find things, if they're asymptomatic, which presumably they would be, because if they were symptomatic, you would have done targeted imaging. But if they're asymptomatic, at the moment, there isn't really an indication for treatment. So given the fact, particularly in young children, that imaging is not so easy to do, it requires sedation. There are potential risks associated with that. The consensus guidelines are to do imaging only for clinical indications and not as a baseline. It's conceivable over the years, if we begin to have treatments that are demonstrated to prevent the growth of small tumors, which we do not yet know is the case. And if the treatments are tolerable, it's conceivable we'll move to a point where imaging becomes more useful, but at least that's where things are right now.
I agree with that. The reason that that the consensus is not to do baseline imaging is we get a lot of information that we generally don't do anything with. And so we're putting patients through a lot of procedures, because like you said, a lot of them need to be sedated. And an MRI, if you're doing a dedicated MRI of the brain or brain and spine, MRI of the brain is usually at least an hour. So they can be an hour and 45 minutes where they're getting imaging. And then how often do you repeat it if you found something that may never be a problem? Right? Our hope is that it never is a problem, never needs treatment. But it's hard to, in some ways, justify putting patients through all of those procedures, an IV for the sedation, an IV for the contrast exposure, when they don't need it, or we don't know that they need it. I agree that if we get more information about how small tumors respond, then potentially that risk-benefit analysis changes and we start doing more MRIs. Same thing goes for plexiform neurofibromas. To look at a whole patient, you'd have to do a whole body MRI. You can miss small tumors. So I would not rely on a whole body MRI as a dedicated brain MRI. You're not going to see all those details. Just way too many images to try to do a whole body. But perhaps in the future, one of the studies that we're looking at opening will help answer that question about whether or not a whole body MRI could be helpful.
Thank you, Dr. Korf and Dr. Metrock. One other question before we do a break related to that is UBOs, unidentified bright objects, those little white spots that sometimes show up on a brain MRI. What are they? Should they be of concern? And is there any response?
Yeah, these are areas that show up, as you say, as bright with particular kinds of brain imaging. And they're very common, maybe even universal in children with NF1. And if they don't push on surrounding structures and enhance with contrast, then there's really no evidence that these are tumors. We don't know for sure what they are. They seem to be areas of increased fluid, probably water content within the myelin in the brain, and they tend to disappear over time. There's not really, complete consensus on whether they correlate with learning issues, but we view them as incidental findings that don't require follow-up. unless there's a concerning feature, like if they're pushing on anything surrounding them. And certainly if they enhance with contrast, those are things that would raise question of glioma. But if they don't do those things, we don't usually see a need to follow them.